Well, friends, today we will be talking about an approach to upper GI hemorrhage. This is a very important topic from the point of view of the kind of patients that we have in emergency. More importantly, a lot of changes have happened in the context of management of upper GI hemorrhage. That's why this topic needs to be revisited from that perspective. Now, as we mentioned, then what are the indications of surgery? As I mentioned, indications of surgery may be written here as 6 of them, but these would happen quite rarely in the context of our current day practice. Let's see, hemodynamic instability despite vigorous resuscitation and 6 units given, patient is not stable. So that's a patient who is not stable despite giving blood transfusion. He remains unstable, and that's where we have to sort of offer other modalities than endoscopic modalities, and here transarterial embolization or surgery would be the options. Failure of endoscopy and failure of endoscopic techniques, which we have already mentioned. Shock assisted with recurrent hemorrhage. Initially we have controlled and then the patient is having recurrent massive hemorrhages. Again, that will be a case where surgery may need to be done. A recurrent hemorrhage after 2 attempts at endoscopic hemostasis. You have done 1 endoscopic maneuver, you have done a 2nd endoscopic maneuver, controlled initially, but bleed happens. Then again, you will have to consider this patient for surgery. And continued slow bleeding with a transfusion requirement exceeding 3 units. The patient is becoming stable but is not completely under control. This will be an iffy kind of indication in the context of upper GI hemorrhage. And chronic gastric ulcer, where we cannot confidently rule out malignancy, would be one more indication to this list. But suffice it to say that the list may include 6 indications, but these happens in today's context very sparingly. And that's good because outcomes are improving not because of surgical interventions, but because of the endoscopic intervention and because of the interventional radiology interventions. So these are the things which have changed. So if I were to write it very pointedly, that it says that surgery is on its way out as far as upper GI hemorrhage is concerned. And to give you a context to it, that of the 100 patients that you'd see, probably 5 patients may actually end up in surgery, and it carries prohibitive mortality. So that's the kind of thing that you have to understand, that though of course as a surgeon we must know what are the options, but we must also know the context in which we are talking. Now, surgical management has said that 10% of the bleeding duodenal ulcer will come into this category, and these ulcers will have these characteristics. The ulcer is larger than 2 centimeter, it is a posterior duodenal ulcer, and gastric ulcers generally have a higher risk of bleeding if they are present. So this kind of situation where we may have to offer surgery may pertain in about 10% of the patients. Now, what surgery to be done? I think this area has also gone tremendous change, and this change has been done by PPI and H. pylori eradication paradigm. So, though so many surgeries are described, but we have come to this conclusion that aim of surgery is simply to control bleeding. Simply control bleeding by underrunning the bleeding vessels or by underrunning the tear. That's all we need to do unless there is an associated structural change that has taken place. So, if I have a bleeding duodenal ulcer, I'll open the duodenum, see where the bleeding is present, put my strategically planned stitches, which I'll tell you how we plan, and control the bleeding and simply close the pylorus not even do pyloroplasty, or may end up doing a pyloroplasty if we find that closure is going to cause some degree of narrowing to the gastric outlet. We are not going to bother about doing vagotomy because PPIs are so effective that there is now considered to be no need for doing any acid reducing procedure, whether it is adding a gastrectomy is concerned or whether it is doing a vagotomy is concerned. Basic refrain of surgery in these patients is to control the bleeding, and that's the most important thing. When I come to gastric ulcer, there too my aim would be simply to do a gastrotomy, see the bleeding point, and take a biopsy and control the bleeding. And further, if biopsy is very important as far as gastric ulcer are concerned, and these biopsies will help us zero down on a possible malignancy and offer the treatment accordingly. So, the important point that I want to mention here is the changing role and changing scope of surgery in patients of bleeding, duodenal ulcer and gastric ulcer. And that's something which we have to be all clear about. Now, controlling the hemorrhage, we have to understand that in the context of duodenal ulcer, we have the bleeding happening from gastroduodenal artery, and this is the point from where the bleeding is taking place. So we have to control the flow from the gastroduodenal artery, from the transverse pancreatic artery, and from the artery as it's divided into giving right gastroepiploic and superior pancreatic branch. So that's by doing strategically placed stitch, either we take a U stitch like this or take 3 stitches and control the bleeding from the gastroduodenal artery. So a stitch is placed, which may be we can use a non-absorbable silk, or we may use a PDS to achieve a good ligation or good transfixation of the bleeding of the vessel around here, that is gastroduodenal vessel, and then a medially placed suture to control the bleeding happening from the transverse pancreatic flow, and the one inferiorly. In this way, we will be able to control the bleeding, and bleeding while taking the stitches, very important to make sure that our stitch is not deep enough to cause any impingement on the CBD. So this is the key to controlling bleeding from the duodenal ulcer: putting a stitch superiorly from the bleeding point, a stitch inferiorly to the bleeding point, and stitch medially to the bleeding point. So these 3 important points are to be addressed. Once this is done, bleeding is controlled, and that is the basic purpose of doing any surgery in the context of duodenal ulcer, in the context of bleeding.